So in pharmacotherapeutics we have finished hypertension, we have finished angina pectoris, we have finished myocardial infarction. Okay, we have even compared myocardial infarction and angina pectoris under acute coronary syndrome. Now we have seen that heart failure can be one of the next consequences after either angina or hypertension or myocardial infarction, or even it can be there as it is even without predisposition of any of these. So let us see what is heart failure, what is the treatment for heart failure, and how we are going to discuss or how we are going to have various treatments for heart failure. As such, we have studied various drugs which are used in heart failure. We have seen many of the things, but we'll go through whatsoever common, we'll go through fast, and whatsoever is new, which will give more importance in that. We have seen the definition. Again, we'll go. Heart failure is a global term. I mean, global means it is widely used for the physiological state in which there is a decrease in the cardiac output, or cardiac output is insufficient for the body's need. That is the simplest and easiest definition. It is the condition in which the problem with the either structure of or the function of the heart, and that impairs its ability to supply or pump sufficient blood, and thus it is not sufficient to need body's need. We have seen it with example of pass and fail with your marks. Suppose we say that it is 35%, then it is pass, and if it is less than 30 or 50% whatsoever, then it is fail. So similarly, if it is not able to drive the minimum requirement, then it is fail. So this is how the definition is. Then let us see next. What are the etiological factors? What is the pathophysiology behind it? And it can be caused by any condition. We have seen it can be after hypertension, which is long-term hypertension because of the injury. It can be because of the long-time angina. It can be because of the myocardial infarction and acute coronary syndrome. In many conditions it is there. So it is caused by any condition which reduces the efficiency of the myocardium, and that leading to overload on the myocardium. Over the time, the increased workload will produce changes in the heart. So why there is increased workload? Because you know, after hypertension, it always causes increase in the workload. Okay, preload, afterload, I told you, please go thoroughly. You should be very much aware of it. These are anatomy physiology terms. So when with the time when there is an increase in the workload, it will cause stress on the cardiac muscle, and it will result into injury. That injury will result into the structural or functional changes in heart, and therefore it can lose the myocardial contractility. So reduced contractility or force of contraction due to overloading of the ventricle. Then there is a reduction in the stroke volume as a result of failure of systole or diastole or both. Then there is an increase in the heart rate, which is stimulated by increased sympathetic activity in order to maintain cardiac output. There is a hypertrophy of the myocardium, which is caused by terminally differentiated heart muscles fibers. They are increasing the size, and the size is increasing to attempt the improved contractility, but the function is not improved. That is what we call as a hypertrophy, or we call it as a scar tissue. Enlargement of ventricle contributing to enlargement and spherical shape of the failing heart. This is we call as a dilatation. There is a differences in both cases. Heart size may increase. Hypertrophy means having a new or scar or fibrous tissue which is not functioning. Only tissue is there. While the another one is enlargement of the ventricle, we call it as a dilatation. So just like elastic, if it is elastic stretched, so what it loses the contractility, it loses the powerful contraction, and the size of that elastic increases. So this is that way. That is very simplest example is elasticity. That elastic which are there usually, most of the apparels they got elastic, or at many places these rubber bands are there. So if rubber band is always kept in a highly stretched condition, then you will find that it has not been able to go back to the normal, the smaller shape which was earlier there, and because of that, that elasticity is being losing. So these are similar thing is there. That is what we call as enlargement. Then next in this is The statistics, if you will see, the prevalence is around 5.1 million Americans in average, approximately in 20 years of the age. 4 lakh new cases of heart failure are diagnosed in the United States annually, and slowly we don't have that much big data banks, so it is difficult, but yes, India is also having growing number of heart failure cases. 1% of adult at the age of 50 to 60 years, 75% of heart failure cases, they have antecedent hypertension. I told you why we should treat hypertension. Hypertension is one of the important cause in heart failure. 10% of adults are having age 80 years or age or older, then they get heart failure, and this is, we can say, age bound failure, and therefore it can be there, but this 10% are having heart failure because of the old age. Then mortality, morbidity, will see the lifetime risk for the people with having more BP, that is BP more than 160/90, is double than that of those persons which are having BP of 140 to 90. Then at 40 years of age, the lifetime risk of developing heart failure for both men and women is 1 in 5, and at 80 years of age, lifetime risk of developing new this heart failure is around 20%. Most frequent cause of hospitalization in the elderly, and it is responsible for around 7 to 12% of all hospital admission. It contributes to around 2,75,000 deaths every year. It is actually more than all type of cancer deaths. So that is how the heart failure is dangerous, how it is a problem. It is associated with the high hospitalization and readmission rates. Therefore, it is very dangerous. Now, how will make various categories of heart failure? How will classify heart failure? Because it needs, when we need to treatment or when we have to specify it, then we should be able to easily tell what kind of heart failure it is. So there are various ways by which, or simultaneously we can have a variety of ways to classify it or to make the categories of heart failure. Very first one, easiest one, is which side of the heart is involved, whether right side or left side of that. So we can call it as a left heart failure or right heart failure. Then next type, on what basis we are doing, is whether the abnormality is due to contraction, that is particularly during systolic or diastolic. So we call it as either systolic dysfunction or systolic failure or diastolic failure. Then next is a degree of functional impairment, that is how much failure is, when we say that failure, so failure with what margin. So suppose we need 90% or minimum 70% of the blood supply regularly, or we call it as ejection fraction. Then if it goes to 60, then it is mild, slightly. So on that basis of how much actually the deviation from the minimum passage, suppose 50% is your passing marks. So some has got 48%, some has got 30%, some has got 20%. So there is a difference in failure. Although all are failure, but there are a few who have missed it by just a small one. So accordingly, then efforts wise, again if we will see, then those who have got 48%, they will need smaller efforts. So similarly over here, a degree of functional impairment which is conferred by abnormality. So what we do is, for that it is a Newark Heart Association functional classification. On that basis it is done. Then whether the problem is primarily increased venous back pressure, that is which is behind the heart, or failure to supply the adequate arterial perfusion. Okay, so we call it as a backward versus forward failure in that case. So second thing is again sort of, we can say, related to right side and left side, because if left side is failing, then there is a forward failure, because failure to supply adequate arterial perfusion, because left is failed and they will not able to do. If right is there, then the blood will remain pooled in pulmonary arteries, because it will not able to do it in that way. So that pooling will be there. So whether it is because of the or it is related to increased venous pressure, or output is affected, whether the abnormality is due to low cardiac output with high systemic vascular resistance, or a high cardiac output with low cardiac resistance, low vascular resistance. So these are low output versus high output heart failures are there. These are again variety of categories we are having. Then types of heart failure, classification of heart failure based on which heart function or which side of the heart is most affected. So systolic heart failure, what we call it as a HFrEF. That is, there is a HFrEF means what? HF is heart failure, EF is ejection fraction. So failure of contraction of pump blood out of the chambers, which is measured by ejection fraction, and if the percentage of blood that is ejected out of the ventricle is there on that basis, normally it should be minimum 50%, up to that it should be there. If it goes just like your farm D passing, it is 50%. So like that it should be there. Then diastolic heart failure, we call it as a HFpEF, that is failure of relaxation of the relaxation to fill the chambers with the blood. So if chambers are not properly filled, then it will not sufficiently available. We call it as a end diastolic volume will not be sufficient, and if it is end diastolic volume is not sufficient, then the pumping will not be sufficient. So these are two important ways by which we can do. Then next in this is, let us see the differences, what we are having, how it is there. Every beach there is, we know cardiac cycle, or actually I told you, I don't know how many of you are following it, but I told you when you are going for cardiovascular system pharmacology and therapeutics, your knowledge about cardiovascular system should be very good. Every thorough detail about anatomy, physiology should be helping you. If you remember various mechanism or cardiac cycle, then it will help you more. So each bit of the consists of contraction, systole and relaxation in diastole. You know it, you have seen the cardiac cycle. When the heart contracts, chamber of the heart, that is ventricle, they pump out the blood into lungs, that is from right side, and the rest of the body, that is from left side. And when the heart relaxes and expands, the ventricle fill completely with the blood. This is the normal situation. So this is the heart structure, and this is the pumping while systole. Okay, so this is coming. All the heart is in a diastole condition. So arterias are filling, and it is going to, after 0.1, if you remember cardiac cycle, after 0.1 second it goes to ventricle. Then ventricles are contracting, and because of contraction of ventricle, the pumping is there. We call it the systole. This is a normal situation. Now, if we go to next, that is what is the systolic heart failure. So yes, the blood comes normally, similar to this normal. Blood comes here normally, it goes normally, but see here the contraction is powerful, here the contraction is not that powerful, and therefore this since it is not powerful, the whole amount of blood will not be transport to all the aortas, that is pulmonary aorta and the aorta. So this will be there because of the systolic heart failure. Now what will happen in diastolic heart failure? See, this is the dilatation of heart, and because of that you can see the size, you can see the thickness of ventricular in these both. Here what will happen, that here the thickness of ventricle has increased, but the power of contraction has not increased. So what is happening, because of this increase in the size, the size has increased and blood is coming over here because of blood which is coming, but then the overall chamber size, we call it the ventricular chamber size, that has reduced. It is reduced, and therefore when it is pumping, again sufficient amount of blood will not be there. So this is how we make. So whenever it is systolic one, we call it as HFrEF, and when we see this diastolic heart failure, then we call it as HFpEF. So these are how these heart failures are there, and we should be aware about it, because accordingly we will go for treatment. Now what are the characteristics as comparing to systolic and diastolic? Okay, so systolic and diastolic we compare. Example is clinical feature. What are the clinical feature of whether they are different? So they are not that different. Like symptom like dyspnea, that is difficulty in breathing, it will be appearing in both diastolic as well as systolic, because both are actually resulting into decrease in the pumping of the blood, and because of that hypoxia will be there, or sufficient blood, oxygen, blood, nutrient will not be passing. Then whether there will be congestive state, congestive means there is edema, okay, the fluid accumulation in some of the places in the body. So in diastolic and systolic both, yes, because yes, in both cases there will be edema. Whether there will be neurohormonal activation, yes, example of brain natrial peptide, that is BNP hormone, that will be activated, that will be more secreted. So yes, both will be more secreted. Both are same, then what are the difference? Let us see. We have seen by the figure, here we will see. In diastolic, the ejection fraction will be normal, but in systolic it will be decrease. In left ventricular mass, in diastolic it is increase, in systolic also it is increase. In the relative wall thickness, in diastolic it has increase, that in systolic it can be decreased. The end systolic volume, in diastolic it may be normal, in diastolic volume it may be normal, and in systolic heart failure it will be increased. Why it is increased? Because sufficiently it cannot be pumped out. Then end diastolic pressure, that will be increase in both cases. Left atrial size, that is increase in both cases because sufficient blood is not going, so atria is also increasing its size. Exercise capacity in all cases decrease, cardiac output in all cases decrease. End systolic pressure, end diastolic pressure is increase in both cases. So this is how we compare with systolic and diastolic, and thus it gives us idea what are the functional changes or functional impact it is causing. Now, what are the clues for differentiating between these systolic and diastolic patients? Let us see again. So, hypertension, it can be in systolic, it can be there, here it will be more. Coronary artery disease, more chances in systolic than diastolic. Diabetes mellitus, more chances in that. Valvular heart diseases, more chances in systolic and diastolic. And physical examination, we can see that how we can do it. So these are important clues, or these are very, very important diagnostic tools which are to be adapted, and this will help us to differentiate between systolic and diastolic type of functions. Then other things are cardiomegaly, yes, it is there with systolic. Then pulmonary congestion is both. Then the QA changes are there in systolic. Left ventricular hypertrophy will be comparatively more in diastolic than systolic. Echocardiogram will show the decrease in the ejection fraction in systolic. Dilation of left ventricular again will be seen, and left ventricular hypertrophy is there. So these are various ways, these are important, and therefore echocardiogram is very, very important in diagnostic, because it helps ECG, echocardiogram, apart from all other tools. They are very, very important, they are very diagnostic and helpful in finalizing the diagnosis. Now on that basis, the New York Heart Association, NYHA, that makes a functional classification. So there are 4 classes it shows, that is class 1 is the mild, class 2 is also mild, class 3 is a moderate, and class 4 is a severe. How we will say that? So class 1 is showing no limitation of physical activity. Ordinary physical activity doesn't cause any tiredness, no heart palpitations, no shortness of breath. This is what we call it as a class 1. Class 2, slight limitation of physical activity, comfortable at rest, but ordinary physical activity results into tiredness, heart palpitation or shortness of breath. That is, if somebody just walk or just climbs 2 floors on staircases like that, then shows signs of tiredness or shortness of the breath, then it means the mild one. The third one is the moderate one, either marked or noticeable limitation of the physical activity, comfortable at rest, but less than ordinary physical activity that causes tiredness. So just like in angina, similarly, if we remember stable and unstable, similar thing over here. So here even almost normal like activity will show it that the person cannot perform it, and there will be tiredness, palpitation and shortness of breath. The fourth one is a severe limitation of physical activity, even at rest, unable to carry out any physical activity without discomfort. Symptom also present at rest, and if any physical activity is undertaking, discomfort is increasing. There is one more classification that is called as a AHA or ACC classification. We call it as a staging system of heart. So stage A is a people who are having high risk for developing heart failure, but they don't have any structural or functional or symptomatic failure. So it encompasses pre-heart failure. Earlier it was called as a pre-heart, or if you remember in hypertension we were calling it as a pre-hypertension. So here it is, we call it as a pre-heart failure. Earlier it was called as a, now we call it as a stage A, and where intervention with management can avoid the progression to the symptoms. So this is the stage A, where coronary artery diseases like angina or ACS, that is acute coronary syndrome, these are various diseases. They are responsible for the failure, although there is no failure, but this is very sure that they are going to cause the failure. Diabetes, hypertension, metabolic syndrome, obesity, using cardiotoxins or alcohol, family history of cardiomyopathy, cerebrovascular accidents, personal history of rheumatic fever. These are some of the places where there is no actual heart failure, but person should have the treatment which is called as a preventive treatment for that. Then stage B is the people with structural heart diseases, but which is without sign and symptom of heart failure. So it is matching with the earlier NYHA class 1. So there are no problems, and no problem are seen, but structurally there are slight changes, and this sign symptom, although they are not now, but they can appear, and if we can take care from now, we can prevent going into the next stage. What are the signs which are seen? Left ventricular hypertrophy is observed, maybe in smaller amount. Reduced left ventricular ejection fraction is known. Asymptomatic valvular heart diseases are there, or previous MI was there. In that cases, it shows the conditions, but it is not severe one. Then next is people with structural heart disease with prior or current symptom of heart failure. There are known structural heart diseases with dyspnea, fatigue, inability to exercise, and this is matching with the New York Heart Association class 2 and class 3A. Lastly, people who have advanced heart failure which is severe and difficult to manage with the standard treatment. We call it as a similar to that NYHA class 4. Marked symptoms are there at rest also. Despite of maximal therapy with recurrent hospitalization, still there is a problem. So these are very, very important, these two classifications are. Okay, whenever, because all your treatment will be based, or your all treatment guidelines or algorithms, they will be based on these two types of grading or staging of this system. That is how New York Heart Association or how this HACC is giving. On that basis, this will be actually giving you. So in 2017, this American Heart Association or American College of Cardiology, they focus update of this 2013 guideline for the management of heart failure, and they have updated it, a few things there. So you will see these, what are these? So here various recommendation at level of evidence, I repeat what it is. That is level of evidence is the highest level is level A evidence. What do you mean by A level evidence? First I will tell you. And this will coming for all your pharmacotherapeutics, first year, second year, third year, in all cases it will be there. That shows high quality of evidence from more than one randomized clinical trials. So there are clinical trials are there, and which are having a very good setup of that, design is very good. Then meta-analysis of high quality randomized clinical trial. High quality means where the number of patients are there, it is very stringently monitored, no chances of any kind of manipulations. All the data is very authentic, then we call it as a very high quality RCTs. One or more RCTs which is corroborated by high quality registry studies. Now what do you mean by high quality registry studies? These are particularly good associations or government agencies which are doing and which are nothing to do, they are actually intended for a correct outcome of the studies. They are not having any kind of bias, they do not have any kind of personal agenda in that. So in that cases, this type of level of quality of evidence is important. Then level B is what this here also we need minimum one RCT is there, but here the quality may not be that good. Quality number of patients, suppose in level A it was more than 10,000, 20,000, it was a big study, multicentric study, so many scientists are involved and big efforts are taken, and on that basis it is there, then it is level A. But the patients are maybe 1,000, 2,000 patients are there, no good characterizations were made, and no good design concept were applied, then it becomes a moderate one. Then level B, non-randomized, so that the whatsoever clinical trial was there, it was not randomized. Okay, the patient, this is what clinical trials are there. There are two types of clinical trials, randomized and non-randomized. Randomized means patients are randomly selected, nobody has put anything, take this. Suppose I take 5 patients, I want to take 10 students up from your class, okay, and I select all the brilliant students. Then what will happen? Then if I have to go for doing any kind of work or maybe project or maybe some examination or maybe test, then if I select this 10, then my group will be much better than any other's group, because I have selected typically 10 best students. But if it is randomized, then I may get any kind of student, the other also can get any kind of students, and then it will be comparable. So these are called as a randomized one. And in non-randomized, where the selected patients are selected without this one. So if it is non-randomized, then definitely its quality decreases because its trustworthiness decreases. So we call it as a level B, non-randomized. Then level C, limited data. That is, the data is limited, although there was a trial, it can be randomized or non-randomized, but the data is not correct, the design is not that proper, design is having some problems, or execution is not that way, the study statistics are not properly done, and physiological or mechanistic studies are done in human subjects, and which are not as per properly planned design, then we call it as a level C, limited data. Lastly, limited level C, expert opinion, that many doctors are saying it was not studied as a clinical trial or accordingly, but here many doctors, they are telling, many doctors, they are of opinion that this study will, this type of treatment will be very useful, and then it is useful, and then we can go for that, like that. So it is opinion is there, and there is a consensus of opinion, means everybody is agreeing upon it, that is this type of thing should be done, we call it as a consensus of expert opinion. So these are various level, we call it as a quality of evidence, and this will be always there. So always those who are qualifying in the level A, they are always will need the first line drug. Then those which are comparatively less, one by after, they will be second line, third line drug. Okay. So where the safety or where the benefits will be more, we have seen benefit versus risk. Where the benefit is more, then this will be always accepted, where than those which are having comparatively narrow gap between benefits and risk. And lastly, where benefit are equal to, almost equal to risk, then they are we will go for the line 3, third line or fourth line, like that. They will be less preferred, and definitely there is no point in going when the risk is more than that of benefit, because there is harm. You know? because we have to purchase the drug, we have to go for a doctor, we'll pay the doctor fees, we'll purchase the medications, and then we say we'll be giving the drug which is having more risk or more harm than the disease itself. There is no point in going for that. So this type of situation is there. Now let us see various drugs in that. Class 1 drug which are having very strong, always I told you where benefit is much more than risk. So risk is minimum 1 and benefits are more. So they are always first line, they are always useful, they are always beneficial. Then class 2, they are moderate one where benefit and risk, that is the gap is less. In first one they are strong, benefit is very much than risk. In second one benefits are more than risk. In class 3 there are benefit are maybe slightly greater or almost equal to risk, and if there are no benefit then there is no big benefit, then we shall not be giving. And lastly class 3 harm, where risk is more than benefit, there is no meaning of it. So this is how we call it as a evidence base. In 4th year therapeutics you have got whole topic on that, how we are going to do this. So whole topic will discuss with what we call as evidence based medicines. So once that evidence, and on that basis only we have got grades of disease, for which grade which medicine is best, and if it, where it has been proven, everything data is there, then we will get a guideline. The guidelines are made on what basis? That all these studies are done. There are patients with this kind of symptoms, this kind of pathophysiology, this kind of structural or functional changes, and in this patient when drug A or drug B or drug C or drug D is given, then what are the short term and long term impact of this drug. If short term and long term impacts, they are saying that the drug A was the best, which is having maximum benefits, then we will go for the drug A as the first choice. Okay, and as the condition slightly changes, then in other condition you may find that drug B was better, then we will say that drug B is the first choice, and then drug A or drug C, whatsoever it should be given. So this is how we are making guidelines, this is how we are making algorithms, that in condition which is good. And same thing we have seen during hypertension, same thing we have seen during angina, and same thing we have seen during myocardial infarction. Okay, I hope it's clear. This is very important, and you should remember how the guidelines are made, how the algorithms are made. Then next is the details about this 2013 American College of Cardiology and AHA guidelines for the management of heart failure. We call it as a 2013 HF guidelines. And these guidelines, how these guidelines are based, we have seen that how the first line, second line drug are determined on the basis of the evidences. The scope of the focus update, that includes revision to the sections on, that is what are various biomarkers will be there. I told you about biomarkers during myocardial infarction. So every time there will be some biomarker for various diseases, and this biomarker, their levels, the changes, they will be indicating type of problem and severity of problem. Then new therapy which are indicated for stage wise CHF with reduced ejection fraction, that is having HF-REF. Then updates on HF with preserved ejection fraction. Okay, so HF-REF is a reduced ejection fraction, HF-PEF is a preserved ejection fraction. What is the new data on important comorbidities? You know, we have seen that heart failure is always or most of the cases as a consequence of some other thing. What are these other things? Usually it can be hypertension, it can be diabetes, it can be hyperlipidemias, it can be angina pectoris, it can be myocardial infarction and some other such conditions, or rheumatoid arthritis. So these are various comorbidity including sleep apnea, anemia and hypertension. These are important comorbidity. What do you mean by co means simultaneously. Morbidities means which are the diseases which compel person to go for treatment. Okay, so these are the comorbidity. Co means simultaneously, and morbidity means the morbidity and mortality. This word are very commonly coming. Mortality means any disease which is resulting into death, we call it as a mortality. Morbidity means the disease which will result into going for treatment, particularly long treatment. This is comorbidity, or rather hospitalization. So these are comorbidities. And any new insight in the prevention of heart failure, these all things will be these are guided by these guidelines. So let us see initial and serial evaluation of heart failure. So what are these? First are the biomarker. What are the biomarkers we can see is, okay, it shows that ACC and AHA, that staging is there. So it shows that if the person is at risk, then what we should do is we should check about BNP, or pro BNP is a fact which is there, so that can be checked. Then ACC, AHA stage C and D. Okay, we have seen A, B, C, D, 4 stages are there. So these are the first one are there at risk, means we cannot see big structural changes, but we can see what are they. Then next are having stage C and stage D, which are ambulatory. There are two classes in that. Ambulatory patients, ambulatory means they can come to hospital and walk away, they can go back, or they will coming as a outpatients. Okay, so in that BNP or anti-pro BNP can be checked. In NYHA class 2 to 4, then we will go for BNP or anti-pro BNP core 1. These are the diagnostic, or these, that is brain natriuretic peptide. Okay, so this everywhere how we are going to have this, that is brain natriuretic peptide at various level, and this will give us idea this how this is helping us. That what it is, BNP I told you, brain natriuretic peptide, and NT is N-terminal pro B type natriuretic peptide. Okay, that is its analog. So these are various ways by which we can have, and the class of recommendation COR1 or COR2 means which kind of drug we will be recommending. If we find this, then we will find that this is active. Then other biomarkers are there which are called as a biomarkers for injury or biomarkers for fibrosis. I told you there is a condition where there is a fibrosis or fibrous tissue is developed. We have seen there are two things, hypertrophy and dilatation. So hypertrophy is there where the fibrosis is there, and because of fibrosis the fibrous tissue is there, just like we have seen earlier, I think where we have seen it, in injury and repair scar tissue. So in that it is there, similarly it will be there, and the biomarker of that is soluble ST2 receptor, they will be found. Then galactin will be there, high sensitivity troponin, these will be observed, and they will give indication that yes, now there is a formation of hypertrophy. So these are various conditions, and accordingly we can go for various treatments, go for checking other biomarkers of the myocardial injury or fibrosis, and accordingly go for treatment, either class 1, class 2, class 3, whatsoever is there, and this will help us into management of the hype. So what are these? So class of recognition, suppose second A, that is we have seen classes or grades. For the patient at risk which are developing HF, then natriuretic biomarkers based screening will be followed by doctors, and then they will suggest what should be going for, what is the level, and accordingly what should be done. Then this type or this COIR is 1. Then in the patients presenting with the dyspnea, measurement of natriuretic peptide is useful to support the diagnostic or exclusion of heart failure. So these are various biomarkers. They are used in various conditions. So biomarker for prognosis. Prognosis word I have already told, it is very, very important. You should always remember. Prognosis means, suppose we diagnose the patient and we found that the patient is in class B or grade B or grade 2. Now there are two things, either or three things rather we can say. With treatment he can come down, he can back to the grade 1 or A, or the person can progress into next one, that is from 2 to 3 or from B to C, okay, and otherwise remain in that, and it will remain stable without any progression, but no back, no forth. So there are three things which can happen when treatment is started. So this thing, after a certain period of time, what will be the condition of the person, we call it as a prognosis. Okay, if the person gets cured, gets well, or the risk factors they decreases and beneficial factor increases, we say that very good prognosis. Okay, then if it is remain as such, we will say that stable prognosis. But if the person progresses into the next grade, which is more harmful, then we will call it as a poor prognosis or prognosis not good. That means our efforts only we can reduce, we can slow the occurrence of the bigger problem. We are just slowing it down, but we are not preventing. So this is very important understanding, that is what is prognosis, and then accordingly what are various risks which are added and what strategies can be done. So this measurement of PNP or NT-BNP, they are useful for establishing prognosis or for making disease severity in chronic HF. So in both cases we are doing it, and once we understand, then accordingly we can go for the proper treatment. Okay. So at each level, 2, 2A, 2B and B, or in all cases these are various guidelines we are taking, and accordingly we understand the idea, because class 2 or this is slightly higher one than first one. Here patient may be hospitalized, so before discharge if the natriuretic peptide, if it gone down, then we can say that yes, the patient can be discharged because now BNP has reduced. That means the patient is comparatively better. What is BNP? I told you, brain natriuretic peptide. Why we are measuring it? Because when there is a heart failure, to compensate it, brain releases this chemical, we call it as a brain natriuretic peptide. We have seen one of the drug of this type, that is we call it as a atrial natriuretic peptide. We have seen that various agents which are acting on that, and we have seen the combination of ARNI, ERNI. If you remember, we have studied during heart failure along with AC inhibitors or ARBs. So if you remember this, if you have gone through the earlier studies, it will become easy for you. Okay. Now we will go for various treatment for various stages of A to D or classes 1 to 4, that we shall see in next time. If you have any difficulties, you can definitely ask me. You can put it on WhatsApp group.